Hey all, welcome back to the Real Life Pharmacology Podcast. This is your host, Eric Christensen. I am a pharmacist, board certified in geriatrics and pharmacotherapy. Doing a little bit of a different episode today by request and emails that I get, starting on some of the most commonly used antihypertensive medications. And going to try to break this down into some of the most important things you're going to see on board exams and pharmacology exams, as well as practice pearls. So going to cover ACE inhibitors and calcium channel blockers within this podcast today. As always, go check out reallifepharmacology.com. I've got a free PDF. It's 31 pages on the top 200 drugs. Great study guide, great refresher. An email is all it'll cost you to get that. So again, that's at reallifepharmacology.com. All right, let's get into it a little bit here. We're going to start with ACE inhibitor practice pearls. I would say the most commonly used ACE inhibitor I see in practice is lisinopril. I think that's what most clinicians are comfortable with. You do see occasional enalapril, ramipril, and other medications. Remember that ending. That PRIL, that indicates that it's an ACE inhibitor. When we're starting an ACE inhibitor, I think it is important to pay attention. Generally, we want to start low and go slow, especially in patients with CKD. Okay, it can cause acute renal impairment, but it also can be beneficial in delaying and reducing the progression as well. So, with that said, generally, when we're talking about monitoring creatinine through labs, it's a greater than 30% increase in creatinine is where we're really concerned. So, if you've got a patient's creatinine that goes from 1.1 to 1.2, that's not a clinically significant increase in creatinine. So, pay attention to that. With labs, we're going to monitor potassium as well. ACE inhibitors cause hyperkalemia. This is at much greater risk, obviously, if we've got other meds on board that cause this. Spironolactone or eplerenone. Trimethoprim is an antibiotic. ARBs, obviously we don't want to use ARBs with ACE inhibitors. That's a contraindication. And then potassium supplements. Sometimes patients are taking those, and certainly hyperkalemia risk can be increased if we add an ACE inhibitor on top of that. Avoid ACE inhibitors in pregnancy. This medication class is contraindicated. One of the most common adverse effects you are going to see with ACE inhibitors is a dry cough. And this is due to bradykinin accumulation. If that is bothersome, if it is identified, generally what we're going to do is switch patients over from an ACE inhibitor to an ARB. Another thing to pay attention to, watch for angioedema. So this is swelling of the lips, throat, tongue. This can be a very serious adverse reaction. It is rare. It doesn't happen very often at all. But if you have patients reporting any type of tingling, swelling of the lips, mouth, throat, and obviously, difficulty breathing is an absolute emergency. Pay attention to that. It could be ACE inhibitor-induced angioedema. One thing I wanted to mention, going back to cough, I don't think I mentioned the characteristics of the cough. It is a dry type of cough, and obviously it's going to be chronic if we don't identify that that's an adverse effect. So probably the easiest way to differentiate that from an infectious type cough, with an infectious type cough, typically we have sinus congestion and nasal discharge and things like that. With the ACE cough, we typically don't have that issue. All right, some potential compelling indications, great reasons why we would use an ACE inhibitor. Can be beneficial in heart failure with reduced ejection fraction, patients with diabetes, CKD with proteinuria, and post-MI. Those are kind of 4 classic compelling indications where it's definitely going to be beneficial to utilize an ACE inhibitor. Avoid ACE inhibitors with ARBs, and I would also include ARNI. That would be the medication utilized for CHF, Entresto is the brand name there. Check labs. When are we going to do that? We're going to generally check that creatinine as well as that potassium, usually 1 to 2 weeks after starting or increasing the dose. And wrapping up ACE inhibitors, one kind of classic drug interaction to pay attention to involves worsening renal failure. ACE inhibitors combined with diuretics, combined with NSAIDs, can increase the risk for acute kidney injury significantly. So if you've got a patient taking an ACE inhibitor, definitely do educate those patients very well about taking over-the-counter NSAIDs, because it can definitely increase that risk for acute kidney failure. All right, let's move on. But before we do that, definitely support our sponsor, meded101.com/store. We've helped thousands of pharmacists and other healthcare professionals prepare and pass their board exams. Go check out all the links to the different resources, whether it's BCPS, NAPLEX, ambulatory care, geriatrics, all sorts of different prep materials there. Again, all those resources, meded101.com/store. All right, moving on to calcium channel blockers. So first and foremost, there are 2 main classes of calcium channel blockers, and they do act differently. So the dihydropyridines, amlodipine, nifedipine, these primarily act as vasodilators. Okay, so these are going to be used for hypertension. This is the class that I'm going to focus on mostly here. However, we do have the non-dihydropyridines as well, diltiazem, verapamil. Typically, those are going to be reserved for atrial fibrillation and kind of slowing that heart rate down, whereas the dihydropyridines, primarily are going to be used for hypertension. Most common one I'm going to focus on is amlodipine. Brand name is Norvasc. It is one of the dihydropyridine calcium channel blockers are one of the 3 main classes in the guidelines as far as using for hypertension, along with ACE inhibitors, as well as thiazide diuretics. Peripheral edema. That is the most common adverse effect. It is highly tested on pharmacology exams and board exams. Medications like amlodipine can cause some swelling around the ankles and things like that. So it's due to what's called capillary hydrostatic pressure, and not necessarily fluid overload. Okay, so what often happens if it's not caught is providers will start a loop diuretic to run off fluid, and it might not be that effective because we don't have fluid overload. It's likely due from this adverse effect of the dihydropyridine calcium channel blocker. So what we're going to do, if typically is lower the dose first and foremost. That's a potential option to see if that adverse effects get better. Obviously, we'll look to switch potentially to a different class of medication, ACE inhibitor, diuretic, thiazide diuretic, those type of things if we're using it for blood pressure management. Constipation is a somewhat common adverse effect, I guess. I wouldn't put it crazy high, but that is something to pay attention to. Again, probably more so common with the non-dihydropyridines than the dihydropyridines, but I have seen amlodipine contribute to that as well. You may see this medication utilized for other purposes. Amlodipine you may see for Raynaud's and certain types of anginas. There are potential for interactions. Statins like simvastatin, amlodipine can potentially interact. But by and large, a medication like amlodipine, there really aren't a ton of drug interactions associated with that medication. I'd say the one of note where we've really got a max limitation is simvastatin. So that's kind of through that CYP3A4 interactions there. But again, generally as far as drug interactions, there aren't a ton that are really, really severe with amlodipine specifically. All right, so a couple more things I wanted to touch on. So first and foremost, with amlodipine specifically, dosing is typically 2.5 to 10 milligrams. You may see 2.5 milligrams started in an elderly patient that's maybe sensitive to blood pressure medications. I would say most of the time you're going to see the starting dose of 5 milligrams, and then we titrate that up to 10 milligrams. Now, it can be given once daily, and it typically is given once daily. The kinetics allow us to do that. However, I have had rare cases where patients maybe show some higher blood pressures at night, or they have rebound hypertension kind of later in the day. If we've tracked those blood pressures and noticed that. With that said, I have seen the dose split with amlodipine as well, where we get 5 in the morning and 5 at night as well. But again, most patients are going to do just fine typically with the once daily option there. And the last thing I wanted to mention with amlodipine is with that peripheral edema, pay attention to disease states where edema is an issue. So if you've got a patient with cirrhosis or with heart failure, a medication like amlodipine may increase that risk for that edema and swelling. So again, that might be a situation where we look at that dosing and maybe we start a little bit more cautiously as well. All right, well, that's going to wrap up the episode for today. If you enjoyed this episode, found it helpful, or have comments and suggestions, definitely don't hesitate to reach out, mededucation101@gmail.com. As always, if you found it beneficial, do me a huge favor, leave a rating or review on iTunes or whatever platform you're listening on. And of course, support the sponsor, meded101.com/store. All your purchases there go directly to support this podcast. And lastly, if you want that free PDF, it's 31 pages, go to reallifepharmacology.com. Simply an email will get you access to that, and then we'll get you emails out when we've got new podcast episodes available, as well as other content too. Thank you so much for listening. Take care, and I hope you have a great rest of your day.